All right. Hello, everyone. Hey, everyone. We're so excited to have you here today. I know we still have some people coming in, but I know I don't want to waste anyone's time. So we're going to go ahead and get started with our exciting presentation today. Today, we have Kerry Jordan talking about some dementia risk reduction. So I'm just so excited. This is going to be such a great presentation. I know she's got such a great conversation to talk about, and I know everyone is so excited to hear it. Before we get started, I did want to share a couple BeWell just side information. So we do have all the biometric screenings open on at the Student Health Clinic right now. So I know it seems like you've got a lot of time, but unfortunately, we were just talking about this. Time is fine. I feel like I can't believe it's already almost July. So be sure to go ahead and get that appointment booked as soon as possible at the Student Health Clinic if you want to get your screening done there. Of course, you can always go to the your own primary care physician if you would prefer to get that done as well. So I think that's really the only other Be Well we have update we have right now. So just to introduce Kerry Jordan, she is a associate professor here of nursing here at UCA. She's a registered nurse for 39 years, and Dr. Jordan cared with many people with Alzheimer's disease and related dementias. This experience motivated her to specialize in gerontology with an emphasis on ADRD during her graduate level training. Dr. Jordan is the recipient of two prestigious national awards, Jonas and the PEO scholarships. She's an Arkansas Gerontological Society Fellow and has presented and published on various gerontological issues at state, national, and international venues. Dr. Jordan has taught at the UCA School of Nursing for 20 years. Dr. Jordan also holds national certifications as a clinical nurse leader. Her leadership and vision for the UCA Interprofessional Therapeutic Activity Program, ITAP, began in 2020 when she developed the idea of merging needs for caregiver respite with student needs for experiential learning. She assembled and led a team of professors to perform a needs assessment and implement the first student-led therapeutic activity, STAP, program at UCA and has since managed both STAP and resilient care support groups. She had led the team in seeking sustainable ongoing funds for ITAP programs, including developing grant proposals, with three being successfully funded. So, with that, we are so excited to have such an amazing presenter today, and I'll go ahead and let you take it away.
Well, thank you so much, Madeline, and I appreciate the opportunity to talk to you all today. This has been a good presentation for me. I've actually learned some things in preparing for this, so I've enjoyed it. We're going to be going over how we can reduce our risk for dementia today. And hopefully, by the end of this lecture, you will be able to understand the prevalence of Alzheimer's disease and related dementias. I'm going to be referring to ADRD throughout this lecture, and that means Alzheimer's disease and related dementias. So we're going to be looking at the prevalence in the United States and Arkansas. You'll be able to define ADRD and different types of dementia, describe the average trajectory of ADRD, and then describe risk factors for dementia. I am going to primarily be focusing on primary risk prevention strategies. If we have time, I'll talk a little bit about secondary risk prevention strategies, but I don't know if we'll have time or not. So we'll just kind of wait and see how the lecture plays out. So in terms of prevalence, you all are probably aware that dementia prevalence is increasing precipitously, and that has to do with the fact that we have an aging population. So currently, there are more than 7 million people in the United States who have Alzheimer's disease, and that's the most common cause of dementia is Alzheimer's disease. In Arkansas, there's 60,400 people who are age 65 and older who are living with Alzheimer's. By 2050, those numbers are expected to double. So nationally, it'll be 13 million by 2050. And surprisingly, 1 in 3 older people will die from ADRD. It actually kills more people than breast cancer and prostate cancer even combined. And that's even though you hear more about those disorders oftentimes than you do about dementia. And you can see by the bottom point that the cost of dementia is increasing in the US as well. It's expected to be up to 1.1 trillion a year by 2050. So what is dementia? So dementia is not a disease per se. It's actually a syndrome. And the syndrome is characterized by progressive and irreversible cognitive deterioration, personality change, and functional decline. When a person has dementia, their brain cells are basically dying for one reason or another. And when those brain cells die, you're not going to be able to get them back. So you're going to tend to see this decline in cognition over time. And you can't, at this point, reverse it. Although they are working to try to come up with ways to do so, that you cannot do that as of yet. This irreversibility of the cognitive changes is what distinguishes dementia from other disease processes. Like, for example, delirium. Delirium is you have changes in cognition, but oftentimes you can reverse the trajectory of delirium, whereas with dementia, you cannot. Depression is another disorder that oftentimes mimics dementia-like symptoms and that you have some cognitive changes, and you can reverse depression by giving medications and whatnot. You cannot do that with dementia. The DSM-5 from the American Psychological Association has defined dementia as a major neurocognitive disorder. And in order to be diagnosed with major neurocognitive disorder or dementia, you have to show evidence of significant cognitive decline from a previous level of performance in one or more of the cognitive domains that include attention, executive function, learning, memory, language, perceptual motor, or social cognition. So you might have changes in a variety of the domains. The key is that those deficits or those changes have to interfere with independence and everyday activities in order for it to really be considered dementia. There's another condition called mild neurocognitive disorder. And this is where you once again have cognitive deficits. However, those deficits do not interfere with the capacity for independence or the ability to engage in everyday activities. So it's really a matter of degree and whether your daily life activities are affected as to whether you have dementia or you don't have dementia. This is a picture, and I'm sorry it's so small I couldn't make it any bigger, but it kind of, I got this from the Savvy Caregiver program that I teach. And it shows you that thinking or cognition involves more than just memory. A lot of times when we think of dementia, we think loss of memory. But you need to keep in mind that cognition involves things like judgment, attention, perception, reasoning, organization, abstraction, and even our ability to create language. And so you have to keep in mind that depending on the type of dementia you have, you might have changes in any of these areas of your cognition. It's not necessarily just memory. And whether you're worried that you or someone you know might have dementia, or you're working with a person with dementia, that's a very important thing to keep in mind. It is not just memory that is being affected when a person has dementia, although memory oftentimes is one component. There are several diagnoses that people can have that can mimic dementia but are reversible. And so I've listed some of those on this slide. One thing to keep in mind is if you are going in and you're evaluated or someone you know is being evaluated, the physician should be looking at these different things that could potentially look like dementia but aren't. And I might add to one of those, and that would be medications. Sometimes you can give certain medications that have side effects that can lead to cognitive changes that are fairly significant. And so it's good for whoever's evaluating a person for whether they have dementia or not to make sure and look at all these different potential other causes of dementia-like symptoms because they are reversible and you can do something about them. All right, so let me talk about just briefly about some of the different types of dementia. A lot of people think Alzheimer's disease is the only type of dementia, that the two terms are synonymous, but that's not true. Alzheimer's disease is a disease that causes most of the dementias in the United States. In fact, 60 to 80% of dementias are caused by Alzheimer's disease. However, there's other types of diseases that can lead to dementia as well. And the three big ones are Lewy body dementia, vascular dementia, and frontotemporal dementia, each of which can cause anywhere from 5 to 10% of the dementias that we see in the United States. And then people can also have what's known as mixed dementias, so they can have a mixture of the different types. And so it's important to keep that in mind. We're going to look at the big four here on the next few slides and kind of look at what's going on pathophysiologically with each of these diseases. So Alzheimer's disease is caused by two primary changes in the brain. And they are the presence of beta amyloid. And beta amyloid is a fragment of amyloid, and it tends to clump together and form plaques in the brain in a person with Alzheimer's disease. It is unknown what causes those plaques at this time. There is another protein called tau protein, and usually these proteins are stabilizing in healthy neurons and healthy brain cells. But in the case of a person with Alzheimer's, these neurons start to form tangles within the brain. And that eventually leads to cell death and problems with cell communication as well. So amyloid plaques and tau tangles are common in Alzheimer's disease and are present in Alzheimer's disease. Vascular dementia, on the other hand, is a disturbance of blood supply in the brain, sometimes referred to as mini strokes over time. So you either have damaged blood vessels or you have interruption of blood flow by a clot or something of that nature that causes a lack of oxygen to the brain, and therefore the cells die. One thing to keep in mind about vascular dementia is that the disease progression tends to be more stepwise and faster than someone with Alzheimer's disease. So with Alzheimer's disease, you tend to see the decline steadily going down over time. With vascular dementia, there tends to be stair steps over time as the person loses cognition. Vascular dementia is associated with the same risk factors that you have in cardiovascular disease, such as smoking, hypertension, hyperlipidemia. And so the prevention strategies are very similar to those of the heart. Oftentimes they say brain health is heart health, and that's one of the reasons why. Or heart health is brain health. So the same things you do for your heart are going to be the same things you're going to do for your brain in terms of preventing vascular dementia. Then we have frontotemporal dementia, and this is a rare form of dementia, which tends to occur in people who are younger than 60. It's associated with abnormal amounts or forms of proteins called TDP43 proteins. It leads to a shrinkage of the brain, affecting primarily the frontal lobes of the brain. You tend to have more behavioral abnormalities in the early stages of a person who has FTP. And you tend to have changes in terms of clinical changes, such as apathy and impairments in abstract thinking, along with speech and language, rather than memory, at least at the very beginning stages of this disease. Obviously, a famous person who has frontotemporal dementia and has been quite open about it is Bruce Willis. One of his problems was he couldn't recite his lines, and so they finally figured out he was experiencing frontotemporal dementia. And then the fourth major cause of dementia is Lewy body dementia. And this results in the proteins called Lewy bodies that are detected in the brain, usually at the subcortical level. And this disorder tends to lead to fluctuations in mental status. Most of the people that have Lewy body dementia have very vivid visual hallucinations. We've had several people come through our program recently, and sure enough, they're having visual hallucinations. They tend to decompensate rapidly if they have a medical condition. And one thing that is very distinctive about Lewy body dementia is people tend to develop movement disorders that are similar to Parkinson's disease. So they end up with stiff gait and a masked affect. Their faces doesn't show a lot of expression, and they tend to have more apathy and depression as well. Now, there are other potential causes of dementia, but they're less common, and so I'm not going to cover those, especially given the a lack of time that I have to give this lecture. But just keep in mind that there's other potential causes of dementia as well as the ones that I've listed. This slide shows a trajectory of the average person with dementia. Now, keep in mind that this is average. So oftentimes when I'm talking to people with dementia, they'll say, oh, I only have like 6 years to live from my diagnosis. And the truth is it really varies from individual to individual. You know, people can live up to 20 years with dementia, or they can pass away sooner. So this is simply a law of averages here on this slide. So keep that in mind. But the things I want to point out is that you can go, if you look at, I don't know if you all can see my mouse or not, but you'll notice in the preventative pre-MCI stage, there's really about at least 20 years in there where you may, or the person with dementia may be having molecular and biological changes, but they are not having any kinds of symptoms. Usually you'll start noticing symptoms about 3 years before you're actually diagnosed with dementia. And you're typically a person that's going to be diagnosed with mild cognitive impairment, and that may or may not evolve into dementia. But there's this period of time before you show any symptoms at all that has been a huge focus of both research and the Alzheimer's community. They're really pushing to take more aggressive steps towards preventing dementia when you're in those pre-symptom stages. And that is what this lecture is actually going to focus on, is that preventative measures before you ever get diagnosed with dementia. So that brings me to a discussion of primary, secondary, and tertiary intervention. You all may know this, but primary intervention measures tend to be aimed at susceptible populations in order to prevent a disease from occurring. So you use primary prevention strategies before you see symptoms in susceptible individuals. Secondary prevention has to do with people who have the disease, but they're still not having many, if any, symptoms. And so you screen the person to see if they potentially may have the disease. Now, there's been some very exciting things that have happened on the secondary prevention level in terms of Alzheimer's disease. But as I said, I don't know if I'm going to have time to talk about that. But if I do, I'll let you know at the end of the lecture. And then there's tertiary prevention strategies, which target the person after the symptoms have occurred and the person already has the disease. So for this lecture, I'm going to start by talking about primary prevention strategies. If we have time, I'll talk a little bit about secondary prevention strategies. We will not be talking about tertiary prevention strategies today. So with that in mind, let's look at the non-modifiable and modifiable risk factors for dementia. So the non-modifiable risk factors means there's nothing you can do about it. This is, baked into the cake, and you just can't really change these risk factors. And there's three big ones. The biggest one is age by far. It's been shown over and over that the older a person gets, the more at risk they are going to be for getting dementia. In fact, there's been some studies that have shown that 40% of adults who reach 85 will start developing dementia symptoms. So that's like 1 in 2 people almost will have dementia if you reach the age of 85. Race is another factor. It has been demonstrated that African Americans, Hispanics, American Indians, and Alaskan Natives have higher rates of dementia. And then you may have a genetic predisposition for dementia. They have isolated gene, the APOE4 allele. If you have 2 copies of that gene, you're at 10 times the risk of developing Alzheimer's disease compared to those who do not have the disease. Now, I will mention briefly, they don't routinely do genetic testing for these genes. And the reason is because you could have the disease and never get Alzheimer's. You could have the genes and never get Alzheimer's disease. And so to date, they do not routinely recommend genetic testing for these particular genes for that reason. Okay, so what are the risk factors for dementia? And I will say that I obtained most of the information from this lecture from the Lancet Commission report, which was put out in 2020. And this was an incredible report where they just did a tremendous job reviewing all the evidence out there related to risk factors. And so it was very evidence-based and very impressive. And much of the dementia recommendations today are based on this report, actually. So you can see the risk factors listed on this slide. I excluded one, and that was air pollution. And that's because we don't have a lot of time to talk about these risk factors. And air pollution, I thought you can't really do much about that individually. So I left that out. If you look to the right side of the slide, this is a figure that was developed by the Lancet Commission report. And you can see that they've divided these risk factors into early life, midlife, and later life. So these are different interventions you can perform at different stages of life. And they've also attached a percentage to each of them. And this is the percentage reduction in prevalence if that risk factor were eliminated. And you can see that it's additive over a lifetime. So if you add up all of these risk factors and you're able to reduce them, you can reduce potentially the prevalence of dementia by 40%. So that's pretty amazing. And so all that just to say that paying attention to this lecture might be a good idea. It may help you prevent getting dementia in the future. Okay, so let's look at each of these suggestions, and we'll just go through them one at a time. So what they found is that higher childhood education levels and higher educational attainment tends to reduce the dementia risk of individuals. Cognitive ability increases in early childhood, and it tends to plateau in adolescence. And so most plasticity is obtained in the early years. So that suggests that cognitive stimulation is probably more important early in life, which is one of the reasons why they put this particular risk factor at the top of the list under early prevention strategies. However, studies have shown that staying cognitively and socially active in older life may decrease risk of dementia in those who are over 65 years old. There was one large study in China that had over 15,000 people that was consistent with this finding of the effect of cognitive stimulation in older people. And there are several smaller studies that backed it up. There's a hypothesis out there that you can either use it or lose it. And this hypothesis is supported by multiple retirement studies that have been done. One retirement study showed that people that were in more cognitively demanding jobs tended to show less cognitive deterioration, both before and after retirement. Another retirement study showed that there was a twofold increase in episodic memory loss associated with retirement. So once you don't have that stimulation of retirement, your episodic memory tends to decline. And also verbal memory declined in those retiring at 61 years old compared to those who retired later. So all of this just to say, your job really keeps you socially active. I've been thinking about retirement lately, and this is one factor that would say, well, maybe you should stay in the job a little bit longer to keep that stimulation up. If you don't, however, and let's say you do retire, it would be important to stay as cognitively active in older life as you possibly can through reading, playing games, problem solving, and the like. Now, some people have wondered about these. There's some games you can play online and things of that nature in terms of it helping you to maintain your cognitive alertness. Thus far, there's been mixed results in terms of the evidence supporting those cognitive training programs. That doesn't necessarily mean that they're not valuable. I think there probably needs to be more research done in terms of evaluating their benefit. Okay, this is a really surprising thing, but that is that hearing loss has definitely been associated now with cognitive decline. It's a strong risk factor for development of dementia. Some researchers believe that hearing loss is up there with hypertension and diabetes in terms of its effect on cognition. So it's really come into the limelight in terms of risk factors. And studies have suggested that there might be several reasons for this. One is that reduced cognitive stimulation tends to shrink areas of the brain which are normally dedicated to processing auditory information. And not only are those areas of the brain shrinking, but then you're diverting your attention, if you can't hear, so hard to just being able to hear what another person is saying and process it, that it tends to divert cognitive resources away from memory, attention, and executive function to just the process of hearing. So this has been backed up by brain imaging studies, which show that people with hearing loss have faster rates of brain tissue loss, particularly in areas responsible for memory and cognitive processing. And there's one other factor associated with hearing loss that may be playing into this increased risk for dementia, and that is that hearing loss eventually results in people becoming socially isolated because they can't hear, so it's hard for them, so they just socially isolate. And that social isolation itself tends to lead to more cognitive decline. So that may be at play here as well. So what can you do about this? Well, at all ages, it's important to protect your ears from excessive noise exposure. If you do have hearing loss, getting hearing aids are going to be well worth it. There are two studies that support hearing aid use. One was a 25-year study of 3,700 people who were 65 and older, and they found that increased dementia incidence in those with hearing problems occurred except in those with hearing aids. The hearing aids seemed to mitigate that. And there was also a cross-sectional US study of 2,000 people who were tested over 2 years. And then 8 years later, they found that immediate and delayed recall deteriorated less after hearing aid use was instituted. So if you're going back and forth as to whether you should invest in those hearing aids, it might be a good idea to do so. Okay, so hypertension is another big risk factor for dementia. The Framingham Offspring Cohort study, which comprised over 1,400 people, lasted 18 years, found that if you have a blood pressure, a systolic blood pressure, that's the top number of your blood pressure, if it's over 140 in midlife, it's associated with an increased risk of developing dementia. And that risk increased further if that hypertension or high blood pressure continued into later adulthood. So it's thought that midlife hypertension is associated with reduced brain volumes and also changes in the white matter, not with amyloid distribution per se, but that's the underlying pathophysiology behind why hypertension may lead to dementia or may put you at greater risk for dementia. So strong evidence supports controlling hypertension, and the recommended pressure is that you should aim for a systolic of 30 millimeters of mercury or lower to prevent dementia. There have been a lot of studies done on do certain classes of antihypertensive medication work better for reducing dementia risk than others, and they found that it doesn't matter what type of high blood pressure medication you use, what class you use, just as long as you get that blood pressure down. Now, I have down in this bottom point, no evidence supports aspirin or statins to lower dementia risk. I know aspirin and statins do not lower blood pressure, but they are cardiovascular meds, and they're often administered for that reason. So I do find that interesting that they don't seem to be they don't seem to benefit dementia risk. However, I think there are studies ongoing. In fact, I was at UAMS the other day and they were advertising for a large clinical trial related to statins and its effect on getting dementia later in life. So I think there's ongoing studies that way. Okay, exercise and fitness. So there was a recent meta-analysis that had 58 studies in it, and they found that people who take regular exercise may be up to 20% less likely to develop dementia than those who don't. It's hypothesized in terms of the physiology behind this that exercise improves neuroplasticity, which is the brain's ability to adapt and form new neural connections. During aerobic exercise, there is an increase in what is known as BDNF. And this is a protein that supports the formation of new neuron cells. It provides neuroprotection, and it also forms new blood vessels in the brain. So aerobic exercise leads to this increase in this BDNF, which is very good for your brain. Now, they've also shown that resistant exercises, such as lifting weights, are thought to also influence your cognitive abilities through the influence on what is known as insulin-like growth factor, or IGF-1. And so by increasing IGF-1, this can help promote your cognitive abilities. So with that in mind, they recommend that you sustain physical activity, both through midlife, but also that you include a mixture of activity, including aerobic and weight-resistant activity, for best results. And the specific recommendation is that you get at least 150 minutes of physical activity each week, which amounts to approximately 20 minutes a day. And one other last little tidbit here that was interesting is that if you are a completely inactive person and you start doing just a little tiny bit of activity or exercise, that tends to have the biggest impact on your brain. So if you're completely inactive, increasing just a little bit can make a world of difference. So diabetes is also, now diabetes, there's been some very interesting phraseology, and you might have heard that, and that's that Alzheimer's disease has now been called type 3 diabetes. So there's a big interest now in diabetes and how it leads to cognitive issues. And what they've found, one of the hypotheses related to why diabetes affects the brain, is that on the molecular and cellular level, there are some shared features between diabetes and dementia. And so that's where this is coming from. And I'm sure you'll probably hear that if you haven't already, that diabetes, the type 3 diabetes is dementia, because there's a clear connection between the two. Now, they found that the risk of dementia increased with both the duration and the severity of the diabetes. Specifically, there were some studies that showed that if you get type 2 diabetes when you are in your 50s or before you are 50, that your risk increases significantly. So they have done some studies, but they are not sure if any particular medication works better for diabetes. But there are some recent studies on these new GLP-1 agonists. That would be Ozempic, Wegovy, Mounjaro, the weight loss drugs they've been using. And there's some very promising animal studies that have been done that indicate that these GLP-1s may be neuroprotective, and they may help to ameliorate dementia risk. So it'll be interesting to see, those are new drugs, so it's kind of hard to know the long-term impact of them, but it'll be interesting to see what those studies end up showing in regards to using those drugs to try to prevent dementia risk. Okay, weight loss or weight control is another recommended a way to prevent dementia. Studies have shown that if you are obese, meaning your BMI is greater than or equal to 30, and if you are obese in your 40s, that this it's a strong association with late life dementia. And this was a very large study that was done. Now, the thing that was encouraging to me was that this study found that being overweight, which means your BMI is between 25 and 30, was not associated with late life dementia. So it was primarily just those that were obese ended up having more risk for dementia. Oddly enough, there have been studies that have shown that in later life, meaning in past your 70s, if you lose weight, that may mean that you have a greater risk of dementia. So that was surprising to me. There's a U-shaped curve when it comes to weight and dementia. So if you get it early, you tend to be at higher risk. And if you lose weight later in life, that may also put you at high risk. So that was a little bit confusing to me as I was looking at these studies. Um, One thing to keep in mind is that losing weight as an older person might be good because obesity is linked to other dementia risk factors. So, for example, people with obesity are 2 to 3 times more likely to have high blood pressure and type 2 diabetes. So I think in terms of the loss, how much you should lose weight and at what age, I think following your doctor's recommendations here might be a good idea, given the odd time of losing weight information related to these studies. The biggest recommendation is just try to maintain a healthy weight, starting from the age of 30 and going through the age of 65 years old. And if you do that, you will be helping your dementia risk. Oops. Now, there are some psychosocial aspects of life that can also lead to increased dementia risk. Specifically, depression is known to be associated with dementia. Now, once again, this is a little bit confusing in terms of the research, and that is because a lot of people with dementia get depression. So there's a question as to whether depression leads to dementia or the person's depressed because they have these changes that are going on in their brain that are causing the dementia. So it confuses the research a little bit in terms of depression. So we also don't understand whether the length of depression, the severity of the depression, or the age at which someone experiences depression affects depression risk. However, we do know, and there was a large study that was performed that showed that those who were treated with medication, psychotherapy, or both had lower risk of developing dementia compared to those who were untreated. So I think in regards to depression, the rule of thumb is you should just get treatment for it one way or the other, and you can't go wrong in terms of decreasing your risk for dementia associated with depression. Another social factor that has been associated with dementia is social isolation. And this has been demonstrated in several studies. There's fairly strong evidence. And when they talk about social isolation, they're talking about whether a person lives alone and whether they see friends and family regularly or engage in social and community activities. They differentiate this from loneliness, where a person just feels lonely, a feeling a person has. In a large systematic review of 800,000 people, they found that dementia risk was elevated in lifelong single and widowed people compared to those who are married. And they think that part of that is because of this connection between social isolation and dementia. So what can we do to help ameliorate this risk? Well, we can develop policies that encourage social activity across the life course for all. Unfortunately, I think our societies have made us more socially isolated. And so just keeping that in mind in terms of policies into the future might be a good idea. There's no evidence that specific activities are more protective than others, although there was one systematic review that found that facilitating meeting and discussion groups for those who were over 60 were associated with improved global cognition. So there's a need for more study in this area. And just keeping in mind that being socially isolated is not healthy for your brain. Smoking, um, smoking, smokers are definitely at higher risk for developing dementia. And that's because smoking, as you know, worsens cardiovascular risk, which then in turn worsens your risk for dementia. So the recommendations are to avoid smoking uptake, and even smoking later in life may prove helpful. A study of 50,000 men aged older than 60 years old who stopped smoking for more than 4 years compared to continuing substantially reduced dementia risk over the subsequent 8 years. So that was an encouraging study. And if you've got the habit and you're later in your years, it certainly wouldn't hurt to quit smoking even at this late date. The evidence is less pronounced in terms of the effects of secondhand smoke, but the recommendations from all the major Alzheimer's organizations are to avoid secondhand smoke, even though the evidence is not as robust in that area. Diet, you all might find this kind of interesting. I did. But certain diets have been suggested as a means of preventing cognitive decline in people with intact cognition, specifically the Mediterranean diet. And I have a slide on the right that kind of shows what that involves. Mediterranean diets have high intakes of vegetables, legumes, fruits, nuts, cereals, olive oil, and low intake of saturated fats and meats. And also there's a diet known as the Scandinavian diet, which involves whole grains like rye, barley, and oats, fruits, berries, vegetables, especially root vegetables, and then fatty fish like salmon and mackerel. Both of those diets have been recommended to prevent cognitive decline. It's not known how long you need to be on this diet for the effects to take effect. And here's the thing that I found most interesting in this section, because I don't know about you, but I hear those ads every night about the different brain health supplements that you can take. There is no scientific, or I'd say good scientific support for dietary supplements as a means to prevent dementia at this point. It doesn't necessarily mean you shouldn't take those supplements, but there is no current support for it in the literature. So instead of wasting your money on those things, you might consider other means of preventing dementia. Okay, we've just got a couple more here. I'm going to talk about sleep and then traumatic brain injury, and we'll be done. So sleep poor sleep, which can be caused by a number of things, circadian rhythm abnormalities, insomnia, sleep apnea is a big one, has been associated with higher risks of all-cause dementia and specifically Alzheimer's disease. And there was a big study that showed that those who got less than 5 hours of sleep per night were at much higher risk for dementia. But interestingly enough, there was also an association between getting a lot of sleep. So if you had 10 or more hours of sleep a night, there was an association with dementia risk. So primarily the recommendation is try to get 6 and 8 hours of sleep a night. Don't sleep too little and don't sleep too much. There is not a recommendation for you to take sleep aid. So in order to enhance your sleep, it is recommended that you do not take sleep aids. You try non-pharmacological measures such as bed hygiene and whatnot before you go to medications, especially benzodiazepines to help you sleep. Alcohol, another behavior that is associated with excessive alcohol use with dementia risk. So drinking alcohol in moderation has not been conclusively linked to an increased risk of dementia. So recommendations are to limit alcohol use, not to necessarily abstain from it completely. And the Lancet report recommended 21 units of alcohol on a weekly basis should be the max amount. However, there's other places that recommend 14 units of alcohol weekly. So I'd say between 14 and 21 units of alcohol weekly is what is recommended in order to not increase your risk of dementia. And finally, I'm just going to talk briefly about traumatic brain injury. a single traumatic brain injury, and a traumatic brain injury, what you're talking about is mild traumatic brain injury would be a concussion, severe would be a skull fracture. But a single TBI is associated with widespread hyperphosphorylated tau pathology. And those with a genetic tendency for Alzheimer's have increased pathology in the hippocampus specifically. Older adults also are more likely to die from TBI compared to all other age groups. You can see on the slide to the right that 47% of falls, 40% of TBIs are caused by falls, and those often happen in older adults. There's a lot of European studies that back up this information. So the recommendations then are to take safety measures, especially if you're an older adult, but also if you're driving or if you have younger children involved in sports, you really want to consider whether the risk of TBI is worth it given the substantial increase in dementia risk that you will incur if that occurs. So I believe that I'm out of time. So I don't know that I have time to cover these next few slides, which go over secondary prevention strategies. Madeline, if you could chime in and just let me know what your thoughts are,
Yeah,
we can go from there.
it is 2:30, so I do want to go ahead
Yeah.
and wrap up so that we can do that. But
Right,
if it's okay with you,
right,
you can share your slides with me and I can put them on the BeWell website if that's okay with you.
right. I kind of went over, didn't I? I'll be darned.
No, that's okay.
I always talk more than I plan to. I don't know why that
No,
is.
you're fine. Well, it was amazing information. I
Yeah.
feel like I just learned so much. I don't know about all the attendees, but it really will be so helpful. And yes, I see someone ask if this will be on YouTube. The recording will be on YouTube. I'm gonna go ahead and share my screen so that I can put let's see. Well, if my computer will work, I'm going to share my screen so that I can put the certificate of attendance on there. If I can get it pulled up. Um, and then if you want, we can open up for, I know some people probably had some other questions. If anyone
Right.
wants to unmute themselves and ask a question while I get this pulled up, you're more than welcome to, or put it in the chat. Okay.
What about a traumatic brain injury as a child? Or are you only talking about when you're
Yes.
older?
Yeah. I'd say it's across the lifespan. You just want to avoid traumatic brain injuries as much as possible.
Well, too late for that. I'm just asking.
Yeah. Yeah. I mean, once again, it doesn't mean you're going to get dementia, but it just puts you at a greater risk for dementia.
Yeah. Someone asked how much risk is hereditary?
That's a good question. And it seems like I read that, but I cannot remember the exact answer to that. But that's a very good question. And, on that chart, 40% of the risk is that modifiable risk factors, and 60% would involve those other non-modifiable factors. So, but I'm not sure how much of that 60% is the hereditary link. Now, one thing I will say, if you have a lot of family members that are getting dementia, like you have both parents have Alzheimer's disease, and that might be a time where you might want to consider a genetic test if your doctor is willing to do it. But once again, it's interesting. They've come up with these new lab tests specifically for Alzheimer's disease. And once again, this is the secondary prevention where they can actually draw your lab and they can test for amyloid in your blood, which is a huge breakthrough because it used to be you had to get a PET scan or a lumbar puncture to be tested for Alzheimer's disease. But they've got these new lab tests. And the question is should somebody who is not showing symptoms get those lab tests?
Mhm.
And a consensus statement from the Alzheimer's Association just came out and they recommend no, you should not. And I think the same would apply for genetic tests. And the reason is that they gave is because once again, it's not predictive. You don't know that you may actually outlive any symptoms that you might incur if you actually do have Alzheimer's, and then you've got this thing hanging over your head that, oh my gosh, I've got amyloid in my blood, which means I'm probably having brain damage. And so right now, in terms of the consensus statement, it is not to get the blood test to test for amyloid. And I would say the same is true with the genetics. The other thing is you're not going to do anything different. They don't have any medication they can give you to stop the process at this point. So that's kind of the thinking.
Yeah.
I don't know if that answered your question, but there are some ethical questions that come up regarding testing for genetics and for the amyloid.
Yeah. I think one thing to think about is in that I'm so like the more you talked about it, I was just thinking, our preventative screening that we do for BeWell, I mean, it measures some of these factors that affect it. It looks for, elevated blood pressure, hypertension.
Mhm.
It looks at your blood sugar if you possibly have diabetes. We look at your weight and how it's trending. So not saying that this is the end all be all just to, help, but this will give you, that's kind of the point of these screenings is to give you a glimpse of what's going on and to give you, a measure of like, okay, maybe my blood pressure was a little elevated or my blood sugar was. So maybe I can go ahead and start working on these things to overall end up, working on hopefully preventing that, you know, dementia later on happening. So, someone said, don't forget staying hydrated helps keeping blood pressure down. Yeah. Yeah, there's lots of things. So, I think that this has been such a great presentation, and I'm super excited and thankful for this presentation. It's been so insightful. So, again, this presentation will be recorded and put on YouTube if you want to refer back to it. And then I'll also get the slides and get those uploaded to our BeWell resource page. If you just go to UCA HR and then click over to the BeWell tab and scroll down to resources, there's just a bunch of information in there as well. So, thank you so much. And thank you everybody for attending. Don't forget to take a screen grab of this screen and upload it to your Health Check 360 Plus app to get your 5 points for attending today.